What is uric acid? Uric acid is the primary end product of purine catabolism in humans. It's derived from two sources. 1. Dietary nucleic acids. 2. Endogenous nucleic acid breakdown. Daily production and body pool. Humans produce about 400 mg of uric acid daily, with dietary intake contributing approximately 300 mg. The total body uric acid pool is 1200 mg in men, 600 mg in women. In gout patients, this pool can swell to 18,000 to 30,000 mg. Overproduction of uric acid. Overproduction occurs due to increased synthesis of purine precursors. The enzyme PRPP aminotransferase regulates this process and is inhibited by feedback from purine nucleotides. Purines like adenosine and guanosine nucleotides also serve as key intermediates in energy metabolism, as ATP and GTP. Purine catabolism and salvage pathways. Purine catabolism. Purine nucleotides are degraded step by step. Phosphate and ribose groups are removed, forming intermediates like hypoxanthine, guanine, and xanthine. The enzyme xanthine oxidase then converts xanthine to uric acid. Salvage pathways. Purine bases like adenine, hypoxanthine, and guanine can be recycled into nucleotides via two key enzymes. APRT, adenine phosphoribosyltransferase transferase. HGPRT, hypoxanthine guanine phosphoribosyltransferase, which is the more significant pathway. Comparison with other mammals. Most mammals convert uric acid to allantoin via the enzyme uricase, making it more soluble. Humans lack uricase, leading to higher circulating uric acid levels and greater risk for conditions like gout. Excretion and renal handling of uric acid. Excretion pathways. About 75% of uric acid is excreted in urine, while the remaining 25% is broken down in the gastrointestinal tract by bacterial enzymes. Renal handling. Renal processing of uric acid involves four key steps. 1. Filtration at the glomerulus. 2. Reabsorption in the proximal tubule, 98–100%. 3. Secretion into the distal proximal tubule. 4. Partial reabsorption in the distal tubule. Despite these steps, only 6 to 12% of filtered uric acid is excreted in urine. Physicochemical properties and preferred terminology. Physicochemical properties. Uric acid's first pKa is 5.75. Above this pH, it exists as the more soluble urate ion. pH dependence. At urine pH below 5.75, uric acid predominates, reducing solubility and increasing the risk of uric acid crystallization. At higher pH, urate predominates, improving solubility and excretion. Preferred terminology. Since uric acid primarily exists as urate in the blood, the term urate is preferred for serum measurements. Uric acid, a key biomarker in gout, kidney function, and metabolic disorders, is measured using a variety of analytical techniques. Phosphotungstic acid, PDA. Rarely used today, this method holds historical significance but has been largely replaced. Uricase methods. The most widely used approach due to its high specificity, simplicity, and cost-effectiveness. Employs bacterial enzymes, such as those from Aspergillus flavus or Bacillus fastidiosus, to oxidize uric acid into allantoin, hydrogen peroxide, and carbon dioxide. HPLC-based methods. Mentioned for their speed and precision but less common in clinical practice compared to uricase methods. The uricase method in detail. Reaction monitoring. Uricase reactions can be monitored in kinetic or equilibrium modes. Quantification often detects hydrogen peroxide, using a Trinder reaction catalyzed by horseradish peroxidase and an oxygen acceptor. Examples of oxygen acceptors. For aminophenazone paired with phenol or substituted phenols enhances absorbance. Alternatives include MBTH, ABTS, and O-dianicidine. Advantages. Offers excellent analytical specificity with minimal interference from most compounds. Produces chromogenic, visible, end products for easier quantification. Minimizing interference in uricase methods. Common interference. Ascorbic acid, bilirubin, and phenolic metabolites, as in kidney failure, can interfere with measurements. Strategies to reduce interference. 1. Ascorbic acid. Use ascorbate oxidase to neutralize its effects. 2. Bilirubin. Add substituted phenols or ferrocyanide to counteract interference. 3. Phenolic compounds. Employ Azure, D2 at 600 nanometers to reduce spectral interference. Sensitivity, precision, and challenges. Technical requirements. High-quality spectrophotometers are essential for accurate absorbance measurement, typically at 293 nanometers. Substituted phenols enhance molar absorptivity, requiring smaller sample volumes and increasing precision. Challenges. Unknown metabolites, as in kidney failure, may cause incomplete recovery. Final detection reactions must avoid competing interactions to ensure accurate color yield. Preferred methods. Current preference is for assays producing visible end products due to higher sensitivity and color yield. Specialized systems and alternatives. Dry chemistry systems. Multilayer film systems. Separate uricase and peroxidase with a semi-permeable membrane. Utilize a leuco dye that oxidizes to produce a colored product. Cellulose matrix pad systems. Combine uricase, peroxidase, and MBTH. Diluted serum reduces interference but ascorbic acid remains problematic. Third system. Separates serum from red cells and uses substituted phenols for higher precision. Electrochemical and biosensor systems. Incorporate uricase linked to oxygen electrodes or fluorescent probes quenched by oxygen. Used in emulsion halide arrays for broader diagnostic applications. HPLC methods. Employ ion exchange or reversed phase columns with detection at 293 nanometers. Provide fast and specific results, often used as reference methods. Traceability, stability, and pre-analytical factors. Traceability and performance. Certified reference materials ensure standardization across labs. A study by the College of American Pathologists found most methods within 3% of target values, meeting clinical standards. Sample stability. Uric acid is stable in uncentrifuged blood, 24 hours at room temperature. Serum, 48 hours at room temperature, 14 days at 4 degrees Celsius, and 4 months at -20 degrees Celsius. Lithium heparin tubes with separator gel, stable for 7 days post-centrifugation. Tube additives. Generally unaffected by heparin, EDTA, or separator gels, though assay-specific guidelines are recommended. Rasburicase interference. The enzyme rasburicase, urate oxidase, can lower uric acid levels ex vivo unless samples are cooled or acidified promptly. Urinary uric acid measurement. Traditional measurement approach. Uric acid is typically measured in 24-hour urine samples for an accurate assessment of excretion rates. Alkalinization for delayed analysis. To prevent uric acid precipitation, especially at low pH and high concentrations, alkalinization of urine is recommended if analysis is delayed. Serum uric acid concentrations and variability. Age-related trends. Serum uric acid levels gradually increase with age, rising approximately 10% between ages 20 and 60. In women, levels significantly rise after menopause, reaching similar levels to men. Metabolic influences. Higher serum uric acid concentrations are linked to metabolic factors, including increased waist circumference, elevated BMI, components of metabolic syndrome. Reference intervals for serum uric acid. General population. Males, 3.5 to 7.2 mg per deciliter, 0.21 to 0.43 millimoles per liter. Females, 2.6 to 6.0 mg per deciliter, 0.16 to 0.36 millimoles per liter. During pregnancy. Serum uric acid levels fluctuate during pregnancy. First trimester, decrease. After 24 weeks, rise, often exceeding non-pregnant levels. Reported intervals include 32 weeks, 1.9 to 5.5 mg per deciliter, 0.11 to 0.32 millimoles per liter. 36 weeks, 2.0 to 5.8 mg per deciliter, 0.12 to 0.34 millimoles per liter. 38 weeks, 2.7 to 6.5 mg per deciliter, 0.16 to 0.38 millimoles per liter. Urinary uric acid excretion. Dietary impact on excretion. On a purine-containing diet, daily urinary uric acid excretion ranges from 250 to 750 mg per deciliter, 1.5 to 4.5 millimole per day. On a purine-free diet, excretion decreases by 20 to 25%, typically below 400 mg per day, 2.4 millimole per day. Biological variability in uric acid levels. Coefficient of variation, CVI. Serum urate, 8.6%. 24-hour urinary uric acid, 16.8%. Seasonal variation. Serum urate levels are 5 to 7% higher in summer months, likely due to changes in hydration and metabolism. Diurnal variation. Small fluctuations in serum urate levels occur throughout the day, typically less than or equal to 0.5 mg per deciliter, 0.03 millimoles per liter. Practical considerations. Population reference intervals. These may need adjustment based on factors like gender, age, and metabolic status. Clinical decision points. Tailored decision points for specific clinical scenarios are often more practical than broad reference intervals. Sample collection timing. Despite seasonal and diurnal variations, specific timing for sample collection is generally unnecessary. Uric acid levels provide critical insights into conditions ranging from gout to kidney disease and cardiovascular risk. Primary uses of uric acid testing. Key applications. 1. Gout. Risk assessment and monitoring the effectiveness of treatment. 2. Cardiovascular and pregnancy risks. Evaluating cardiovascular risks and aiding in the diagnosis of preeclampsia during pregnancy. 3. Urinary uric acid. Useful for identifying the causes of hyperuricemia and assessing the risk of kidney stone formation. Hyperuricemia and its causes. What is hyperuricemia? A condition characterized by elevated uric acid levels in the blood. Frequently detected incidentally during biochemical screenings, though routine testing lacks proven benefits. Common causes. Hyperuricemia results from increased production of uric acid, reduced renal excretion, dietary factors or underlying conditions. Gout, the classic manifestation of hyperuricemia. Pathophysiology of gout. Gout occurs when monosodium urate crystals precipitate in joints and tissues, triggering inflammation and painful gouty arthritis. The big toe, first metatarsophalangeal joint, is the most common site of involvement. Diagnosis is confirmed by identifying crystals in joint fluid. Types of gout. 1. Primary gout. Linked to polygenic essential hyperuricemia, caused by metabolic overproduction, reduced excretion, or dietary factors. 2. Secondary gout. Caused by underlying conditions like CKD, certain medications, as diuretics, or increased nucleic acid turnover, as tumor lysis syndrome. Management of gout. Acute attacks, relieve pain with NSAIDs. Prevention. Lifestyle modifications. Low purine diets. Medications like allopurinol or uricosuric drugs. Target: maintain serum urate levels below 0.36 millimoles per liter to prevent recurrences. Kidney disease and kidney stones. Kidney involvement. Hyperuricemia can lead to gouty nephropathy, acute urate crystal deposition, urate nephrolithiasis, kidney stones. About 20% of gout patients develop uric acid stones. Stones form due to persistent acidic urine. These radiolucent stones are often treated with allopurinol. Uric acid in pregnancy, preeclampsia. Pregnancy complications. Preeclampsia involves hypertension and proteinuria, with elevated serum urate levels potentially playing a role. While uric acid testing is used in this context, its exact clinical significance remains under debate. Inherited disorders linked to uric acid. Rare genetic conditions. 1. Lesch-Nyhan syndrome. X-linked disorder caused by a deficiency in the HGPRT enzyme. Symptoms include severe gout, mental retardation, behavioral disturbances. 2. Other genetic causes. Mutations in PRPP synthetase or glucose-6-phosphatase deficiency can also lead to hyperuricemia. Diagnosis often involves genetic and enzymatic testing. Hypouricemia, definition and causes. What is hypouricemia? Hypouricemia is defined as serum urate levels below 2.0 mg per deciliter, 0.12 millimoles per liter. It is much less common than hyperuricemia. Causes of hypouricemia. 1. Liver-related issues. Severe hepatocellular disease can reduce purine synthesis or impair xanthine oxidase activity. 2. Renal tubular defects. Congenital, conditions like generalized Fanconi syndrome. Acquired. Acute, from exposure to radiopaque contrast media. Chronic, due to toxic agents affecting renal tubules. 3. Medications. Overtreatment with allopurinol or uricosuric drugs. Chemotherapy agents like 6-mercaptopurine and azathioprine. 4. Inherited defects. Rare metabolic disorders such as xanthine oxidase deficiency, combined molybdenum cofactor deficiency, purine nucleoside phosphorylase deficiency. Uric acid and cardiometabolic outcomes. Positive associations with elevated serum uric acid. High uric acid levels are linked to a range of cardiovascular and metabolic conditions, including obesity and insulin resistance, hypertension and renal disease, type 2 diabetes, cardiovascular disease and mortality, both all-cause and cardiovascular specific. Risk within the normal range. Even within the normal serum urate range, higher levels are associated with an increased risk of these conditions. Causality and treatment. The causal relationship between serum urate and these outcomes remains uncertain. Recent trials of allopurinol in hyperuricemic patients with diabetes or polycystic kidney disease showed potential benefits in slowing GFR reduction. The dual role of uric acid. Metabolic functions. Uric acid is often regarded as a metabolic waste product, but it also has antioxidant properties in circulation, which support endothelial function. Prooxidant effects intracellularly, indicating a complex and dual role. Future prospects. Routine laboratory roles for monitoring uric acid levels are still evolving. Emerging research highlights potential clinical applications in managing urate levels to address cardiometabolic and renal outcomes. Thank you for completing the video. Don't forget to like, share, and subscribe. See you next time, bye.